Lovely introduction. So I'll go ahead and start telling you a little bit about thyroid nodules. So hold on one second. Hopefully you can see that, I hope. Okay. All right, so let's start talking about thyroid nodules and kind of what to do with them. We always hear about them and they scare us, but hopefully this will shed some light onto what a thyroid nodule is and what to do with them. So first of all, what is the thyroid gland, right? So it's a butterfly gland that's located in the lower part of the neck. And the job is to really make thyroid hormone. So what does that mean? Thyroid hormones help the body kind of use the energy, stay warm, keep the organs working, and they basically regulate metabolism. That's what a thyroid does. And so what is a thyroid nodule? Well, it's a growth of thyroid cells that forms a lump within the thyroid gland. It's pretty common, up to 10% of women and about 5% of men have them. Hold on, I'm so sorry. Chances of having them increase as we age. So rule of thumb, 50% chance of having nodules at age of 50, 60% at age of 60, and so on. And the vast majority of thyroid nodules are benign, which means they're not cancerous. But a small portion of the thyroid nodules do contain thyroid cancer, approximately 5%. And this is something that we kind of look for. So what are some of the symptoms? Well, most nodules actually do not cause any symptoms. Thyroid tests are almost always normal, even if there's thyroid cancer. They're usually, so if the thyroid nodules produce excess hormone, we may find it on blood work, but only if they are hyperactive, meaning they're overproducing thyroid hormone. Rarely patients have some nodules that cause symptoms, and they can complain of pain or discomfort in the neck. If the nodules are large enough, they can compress the windpipe or the breathing tube, or the esophagus, the swallowing tube. And some patients may, with those, in those situations with those large nodules, may complain of difficulty breathing, especially in specific positions. Difficulty swallowing, and infrequently hoarseness. That's very infrequent sign. So what, if we do find the nodules, what do we do with them, right? So, and how are they found? Most of them are found really actually incidentally. You're getting an imaging study for a carotid, for your big vessels in the neck, or you're getting some imaging for your back of the neck, and this is by accident found. So usually it's incidental finding on imaging. Some of them, if they're large enough, or if they're anterior sitting, you can be found on your exam, your own exam, or a physician's exam. Again, sometimes blood tests may show some abnormality that may prompt a physician to get an ultrasound, but it may not, again, be related, because most nodules are non-functional. They won't change function. But prompting in the, because of the thyroid function tests, may give you some information on the structure. So what causes? Well, we actually don't know what causes thyroid nodules. There are some increased risks. So Hashimoto's thyroiditis is associated with increased risk. Hashimoto's thyroiditis, you may hear as patients having low thyroid function. And that's basically an autoimmune process where your body attacks your thyroid and then the thyroid stops functioning. So that's associated with having some increased risk of nodules. Family history, and patients with iodine deficiency, and that's extremely uncommon in the United States, because we have iodinized salts, we have access to fish, and a lot of iodine products. So that's very uncommon in the United States. How do we evaluate thyroid nodules? So again, we'll start with function tests, right? We want to make sure that we look at T4, T3. So those are actually thyroid hormones. When we look at the blood tests, that's kind of the T3, T4 is basically showing us what's happening with the thyroid at the time of the blood test. Okay, so that's not a very good long-term test, but a really good short-term test. What we like to look at is a TSH, and that's called, that is a thyroid stimulating hormone, and that's a hormone that's made in the brain. And that tells us what is our brain seeing that the thyroid is producing over a period of time, a couple of weeks, over 4 to 6 weeks. And that's a better test to look at in general how your thyroid is doing. So we look at those two tests, and if the nodule is not producing anything, and there's certain characteristics, you know, on ultrasound, for example, that make us get concerned, then we'll offer a biopsy. So we do a lab test, and then we do an ultrasound. And given those two, we kind of put them together and say, okay, do these nodules meet criteria for biopsy? And we'll talk a little bit about that. Usually under a centimeter, not very worrisome. So over a centimeter, and the nodule needs to meet specific criteria for biopsy, and then we'll offer that. And the biopsy is usually done under ultrasound because you really want to make sure that you get in that perfect right spot, even within the nodule. Okay, so let's talk about the biopsy. So the patient has normal thyroid function or low thyroid function, and the ultrasound shows a nodule that we say is concerning and needs a biopsy. So what are some of the results? Okay, so we like to be able to grade things. This just to make it easier for physicians to talk to each other. So if I say grade 2, you know, the other physician reading it will understand. So basically every biopsy gets a grade. And so I'll go through what the grades are. So grade number 1, the system is called the BETHESDA system, but it's basically grading. So when we get a grade of 1, that means that we just didn't get enough cells from the biopsy. And that occurs very infrequently. It occurs in less than 3% of the time. And most of the time, that happens when the nodule contains a lot of fluid. And fluid is almost always benign, so that's never necessarily a bad thing. If we are concerned about the look, but the biopsy is non-diagnostic or not enough cells, we may offer a repeat biopsy. But again, very often this happens with cysts, and cysts are almost usually benign. If you get a grade of 2, that means that there are some cells and the cells look completely normal, and so it's benign. Most of the time, that's the result we get. That's 70% of the biopsies. The chance that this biopsy actually overlooks a cancer, or what's called a false negative result, is super low. So it's a really, really good test to rule out cancer. And that's approximately 3%. I'm going to skip 3 and 4, and we'll go to 5 and 6. If the result comes at 5 and 6, the 5 and 6 grade, then that's suspicious or it is malignant. And suspicious is about 75% chance of cancer, and and 6 is about 100% chance of cancer. And that occurs in only 5% of the nodules we biopsy. Now let's get back to the 3 and 4, and that's, I like to call it the gray area, because there are enough cells to comment on them, but the cells don't look necessarily normal, but they don't look that bad to call it cancer. So we kind of call it the gray area. It's the 3 and 4 category. It happens in about 25% of the time, and if the nodule falls into that category, the chance of cancer now goes to about 15 to 20%, okay? If that happens, we used to take all the patients to surgery because there's really no other way to further diagnose patients. But right now we have genetic tests that are available. We can do at the same time as the initial biopsy. And that genetic test will give us more information. It doesn't tell us, yes, you have cancer, or no, you don't. But it definitely gives us more information to then say, okay, there are no genetic mutations in this nodule. Let's just watch. Let's stay away from surgery. Let's avoid surgery. Or, well, there are mutations and these are a little worrisome. Let's move to the next stage and do the diagnostic surgery, which I'll talk about in a second. So how do we treat thyroid nodules? Let's get back to the beginning. So if the nodule is overproducing thyroid hormone, that means it's hyperactive, okay? It means it's working overtime. And that's this, this particular look. We can get an uptake scan. And that's a nuclear medicine scan. You get a little bit of radioactive iodine, and then we take a bunch of pictures. And what we're looking for is to see if the nodule itself is overproducing hormone, or it's the whole gland that's overproducing hormone. If the nodule itself is overproducing hormone, it's very, very unlikely to be cancer, actually less than 1%. So you don't need a biopsy for that one, and you just need treatment. So treatment in the meantime is medication to kind of calm things down, to make sure that your thyroid function is normal. But then the definitive therapy is radioactive iodine, which I'll leave a little bit for Kathy to talk about later, versus surgery. Radioactive iodine is a pill, but surgery, it's removing the actual lobe where the nodule is located. Usually we see better results with surgery. It's more definitive, but those are your two options. If the nodule is benign on biopsy, so it's category grade 2, we see some cells, the cells look completely normal. What do we do with those? Well, most of the time we just need to follow. We just need to make sure that the nodule is not doing something, such as changing in its characteristics or changing in size. So we repeat the ultrasound in a certain amount of interval of time. Most of the time it's 6 months. And then we consider surgery if patients have symptoms. So symptoms that we talked about: difficulty breathing, difficulty swallowing, pain or pressure in the neck. And so those are really the two reasons that we may recommend surgery if the nodule is benign on biopsy. What do we do if it's in that gray area and we get the genetic result that has some genetic mutations that we're not terribly happy with? That's when the next step is surgery, because at that point, there's no other test that we can offer to truly give a definitive diagnosis of a benign or malignant tumor. So at that point, we would recommend surgery, and usually that means a diagnostic lobectomy. A lobectomy means part of the thyroid is removed. So if the thyroid is like a butterfly we talked about, one of the wings that contains the nodule is what we would remove. Okay, and then at that same time, we would evaluate intraoperatively to look to see, are there any concerning features? Are there any signs that this is indeed cancer, such as invasion into structures surrounding the nodule, or bad-looking lymph nodes? And if that's the case, then we can extend the surgery at the same time. And of course, the other grade is a 5 and a 6, and that usually means thyroid cancer. So let's talk a little bit about that. Some general information on thyroid cancer. So it's the most common endocrine cancer. It's much more common in women than men, about 8 to 1. Causes, again, unknown. There's some risk factors like radiation in childhood, or radiation treatment, then family history, and there's definitely some environmental factors. We just haven't pinpointed what it is. But most have really excellent prognosis. There are different types of thyroid cancer, and that really depends on the cell in the thyroid that the cancer develops from. So the first 3, papillary, follicular, and Hürthl cell, come from follicular type of cells. There's C cells, and that's where medullary comes from. And then there's sometimes, super infrequently, we see cells that haven't decided what they're going to be. They're going to be a papillary, follicular, Hürthl, a medullary. They haven't decided what they're going to be. And those are super, super young cells. They're dividing so fast, they don't have time to become differentiated into an adult cell, and that's what's called undifferentiated. And that is an anaplastic tumor. It's extremely infrequent, but pretty poor prognosis. So briefly about each one of these. Papillary thyroid, most common cancer, 80% of the time you're going to find this one. It's the best prognosis, slow growing. It does like to spread by lymph node. And very often we see that it does spread to the lymph nodes, but again, the prognosis remains excellent. Follicular type of tumors, again, the same kind of origin, occurs in about 15% of the time. It doesn't spread to the lymph nodes, it spreads via blood. And then Hürthle cell is just a subset or a variant of it. And it does spread to other body parts, but extremely rare, as in papillary as well. Medullary, it comes from these C cells, also in the thyroid. It occurs much more infrequently. It's 5% of the time. Most of the time it's sporadic, but there is a familial component, about 20% familial component. And if a patient is diagnosed with medullary thyroid carcinoma, we strongly encourage genetic testing. And this helps your family. This helps you to see what else we need to evaluate you for, but also helps your children to know that they need to be evaluated. And for this particular type of tumor, we look at calcitonin and CEA because that's what those cells produce. So that's what we look at when we follow patients. So how do we work out patients with thyroid cancer? They already had a biopsy. We already know that there's thyroid cancer, but now the patient needs a very good ultrasound. I personally think a surgeon or an endocrinology just performed ultrasound is the best, just because you kind of know what you're looking for, you know where the pitfalls are, and you know where things can hide. If there are lymph nodes that are worrisome, it can be done, the biopsy can be done and evaluate the lymph nodes right at that same time. And then we always do baseline function tests, right? Depending on the type of cancer and the type of tumor markers they produce. Most of the time, patients may need medical clearance, cardiac clearance, and that's something that your surgeon will kind of guide you. Treatment. So the first step in any thyroid cancer treatment is surgery. And so there's really no good substitution for good initial surgery. That's kind of the main treatment. And then you can be offered total thyroidectomy, meaning the entire thyroid to be removed, hemithyroidectomy, meaning half the butterfly wing, and then it may be accompanied by lymph node dissection, meaning the lymph nodes around the thyroid, or sometimes in other parts of the neck, depending on the ultrasound preoperatively. You may be offered radioactive iodine ablation. Again, Kathy's going to talk a little bit more about that. And then we'll give you hormone replacement therapy. But the first and main step is surgery, and then everything else is kind of adjuvant or an addition. So the surgery, like I said, it's the most important part, and the best way to ensure good surgery is find an experienced surgeon. The recommendation is about someone who's done at least 100 cases, actually in general, not a year, but in general, 100 cases in general. Then you are competent to know the pitfalls of surgery. It's done under general anesthesia. It's outpatient, either one night, if it's a total. For me, everybody's a little different. Or if we remove half of the thyroid, patients go home the same day. It's anywhere from an hour to 3 hours. It all depends on what we find. I usually tell my patients that I don't really look at the clock until the end. And then I say, oh, it took me this long, or it took me this long. So sometimes it takes 45 minutes and sometimes it takes 3 hours. It just depends on what the disease is doing. And it's a very small incision. I don't know if you can see it, but the incision is actually here, right here. And she's healed quite well. It's one of our patients. Let me take a picture. The risks of surgery, again, in experienced hands is pretty low. Bleeding infection, less than 2%. There's a nerve that goes to the vocal cords, and chances that it's permanently injured and the patient is hoarse is really less than 1%. We use, at least I use, a nerve monitor, which is a special machine that when the nerve is touched, It gives a waveform and a beep and a sound, so it can be monitored throughout the surgery. And then there are also these little glands in the back of the thyroid, and they're called parathyroids, and they regulate calcium levels. Most people have 4. You really need 1 to function normally. So the chances that none of them work after the surgery, after a total, is less than 2%. After hemithyroidectomy, this is not a risk. And the recovery is, for the most part, pretty easy. It's actually 3 to 5 days, but sometimes you just tell the patients to take a week off. No restrictions on eating, moving, talking, and I expect you to do that in recovery. And most patients just have a little sore throat, and Tylenol is really what you need. In terms of follow-up, again, we do blood work to look for tumor markers, and that depends on the type of cancer. So thyroglobulin if it's a follicular origin, and calcitonin if it's medullary. And then we look at thyroid function tests too, just to make sure that you're feeling good. We also use it to kind of treat you a little bit. We do neck ultrasounds at around 6 months and a year, depending on the rest of the presentation. And we may offer a thyroid uptake scan, just kind of the same scan that we would do for a hot nodule that I showed you. But on this uptake scan, we're looking to see if there's any evidence of thyroid tissue left after surgery that may indicate the thyroid cancer may spread. So some take-home points, okay? A lot of information, but the bottom line is the thyroid nodules are very common, and only a very small number of them are malignant. Surgery for benign nodules are really if the patient is symptomatic, it's growing, or overactive. And thyroid, a couple of things about thyroid cancer, majority of it is papillary thyroid carcinoma, which is the most common and the best prognosis. If you do need surgery, you should find a very good surgeon that has a lot of experience. Like I said, 100 cases at least under the belt. And it's very important to kind of get treated by a multidisciplinary team, so that when you are discussing what's the next step after surgery, that it is a combination of physicians that are discussing this. You want input from radiology, from nuclear medicine, from endocrinology, from the surgery. It's just kind of coming all together and make that decision that works best for each particular patient. And the bottom line is, you're not alone. There are a lot of really good resources out there, and they're available. We're available. So with that, I'm going to end. This is the information for our thyroid and parathyroid center. Sometimes you just don't know what you need. And so this gives you a really easy way to kind of ask your questions and see, do I need an endocrinologist? Do I just go see a surgeon? So, if you call the Valley number and ask for thyroid parathyroid center, that's also an easy way to get to us, and you will most likely get Kathy, who will then guide you, and tell you and how to help you figure out what the next steps are. So with that, I'm gonna give the stage over to Kathy Heron. She's a nurse practitioner, and she's the navigator for the Thyroid and Parathyroid Center. So I'm gonna stop sharing, and then I'll take all the questions after Kathy shares her slides. So hold on one second.
Okay, let's see how
Thank you so much.
Thank you, Dr. Kendall. Okay. Oh, it won't let me share my screen. Are you still sharing?
Trying to get out of sharing. Okay.
Okay, all right. Oh, this is what happened to me before.
Do you want to try to move to the same screen?
Yeah, I think we'll do that. Okay, let's see if this works better. Nope. Oh, heavens to Betsy. Sorry, I'm trying. Now it's over on the other side.
Move the presentation to where your this screen is, where we're talking.
Okay. Oh, am I okay? Can you guys see it? I see it.
Not yet.
Not yet.
Can you hover over the green share screen again and see?
Okay. Oh boy. Nope. Sorry. It should be on this one. It worked before for me. I'm not sure why it doesn't want to work now.
It just changed the setting. So let's see. Try to get, so when you hit the green share screen button, does a bunch of options come up?
Yes.
Okay, so can you
here
double?
Yeah.
There we go. Awesome.
I just had to remember to click the share at the bottom. That's what I was forgetting.
We got there. Good job.
You got there. Okay. So good evening, everyone, and welcome. I'm going to talk to you a little bit about what Dr. Condell mentioned before. After having surgery, is radioactive iodine treatment for thyroid cancer. And the first thing I want to tell you is not everyone requires this treatment. Okay. I'll tell you a little bit about what it is. Radioiodine is called I-131, and it has been around since the 1940s for treatment for thyroid cancer. And it is a pill or a liquid that you swallow. Let's get to my screen. There's our little thyroid picture there. And it's a liquid or a pill that you swallow. And it's a small amount of radiation, but whether or not you need this type of treatment will be determined after you have your surgery. And why is that? The reason for that is we need the final pathology from your surgery. So after surgery, what is removed goes to the pathology department and they evaluate it. And then when you meet with your endocrine surgeon, your surgeon that has taken care of you, they will explain to you what is found during surgery. And that will determine what the risk of recurrence of thyroid cancer is, and that will determine whether or not you need radioactive iodine treatment and how much you need. Sometimes they will just give a small amount called an ablative dose, which is just to get the teeny tiny microscopic cells that may still be there that are not visible during surgery because they're so small. And once that is decided, you discuss that with your surgeon. And as Dr. Condell said, it's excellent if you can be treated by a multidisciplinary team. And we are very fortunate to have that here. We do meet with our multidisciplinary team several times a month to discuss our patients' cases. And on that committee is, Dr. Condell, the endocrinologist, the nuclear medicine radiologist, the pathologist, myself. And it's a discussion so that our patients get the best treatment and the gold standard treatment that they can get for their thyroid cancer. Okay. How do you prepare for this? This is a question I get a lot from patients when they come in for their post-op visits, because it can seem to be very daunting to people. They're like, oh my goodness, I have to have this radioactive treatment, and they get very nervous. So we do talk a very little bit about it if it is required, but there is a lot more preparation that's done with your team. So in conjunction with your endocrinologist and the nuclear medicine team, you will be provided everything that you need well in advance of having the treatment so that you and your family know exactly what to expect and what the potential issues could be from this. One of the most important things is, although it's a small dose of radiation, you do need to maintain distance from your family during the time of the treatment and right after. How long you need to maintain the distance, again, will depend upon what your dose of radioiodine is. And there are very specific instructions for that, for timing wise. The most important, as I've noted here, is children and pregnant women, because we don't want to give children and pregnant women any exposure to even the smallest bit of radiation. Also, something to consider is that there are specific instructions for bathroom use, if you have a shared bathroom, for cooking, linen, and garbage disposal, where you'll need to, wear gloves when you remove garbage, and cleaning. These are all, I did not want to list everything because it's just a lot of information, but there's a lot of good resources out there to tell you exactly what you'll need to do. And I'll backtrack a little bit. You don't get radioactive iodine immediately after surgery. There is a wait time. You need to heal from surgery, and you need to see your endocrinologist, and it's at least a month from surgery before you start to have to plan for this. You also will need to stay home from work for a period of time and not go out, eat out, social events, things like that. But again, it's a short period of time and will be dependent on your dose of radioactive iodine. Okay. Now, the diet that you need to be on to prepare for your treatment will be a low iodine diet. And you may ask why you need to have a low iodine diet. Because thyroid cells take up iodine. And so we want the rest of your body to be as low in iodine as possible so that the radioactive iodine goes right to where it needs to go and doesn't go anywhere else. We want the uptake to be as optimal as possible. So we need you to reduce your diet to 50 micrograms a day of iodine. And I know that sounds like a very small amount. But the low iodine will help the radioactive iodine uptake to give you the optimal outcome. So I listed here common iodine containing foods, and the only reason, the iodized salts, of course, we all know about, but the reason that I listed the other two, the potassium and calcium iodate, is because that might not be something that you've ever heard of in your food. So, but that is something that would need to also be withheld from your diet. Some of the other things that have a lot of iodine in them are seafood, especially shellfish and seaweed, cured foods such as ham, corned beef, sauerkraut, breads, especially white bread, certain foods and medicines like any supplements that you might take over the counter, restaurant type foods, eggs, and milk. Are those some of the very specific things that you would have to hold off on? And it's usually about anywhere from a week to 2 weeks before surgery, before treatment, that you would need to adjust your diet for these items. And then a few days afterwards too, to give the radioiodine a really good chance to have uptake. Now, there's certainly a decent number of foods that you can eat: fresh meat and poultry, potatoes and rice, wheat or rye bread, fresh and frozen vegetables, and fresh or frozen fruit. The reason not to have canned items is because there can be salt in the canned items that can contain iodine. So we want to avoid those. And there is, hold on. There is, as Dr. Kendall mentioned, lots of resources, and I don't know if you can see me well enough, but at the end of the presentation, I have the name of one of the thyroid cancer associations, THYCA, and they provide, we just got these, they're brand new. It's an low iodine cookbook, and you can request these from the organization or from your doctor to help you, kind of read and prepare and do your best to help yourself. And after treatment, some of the things that we see with patients after they have radioactive iodine treatment is a decrease in the salivary flow. So you want to keep your mouth moist. One thing that you can do to help that is lemon drops. Hard candy, just keep your mouth moist so that you don't have that sensation of dry mouth and help increase your salivary flow. You can have increased tearing and you can have nausea, although those are lesser things that can happen after that you feel. Also, we want to make sure that you drink plenty of fluids because that's very important for flushing the iodine from your system. And so we want you to make sure you have enough fluids before, during, and after treatment. So here are the resources I talked about. THYCA is the Thyroid Cancer Survivors Association, and it is a wonderful organization. They have so many materials and resources for patients, that are going through this. The American Thyroid Association and the American Association of Endocrine Surgeons. All of their websites are very easy to navigate, and I'm not really that good at computers, so I will tell you they are super easy to navigate. So you'll be able to find any information that you're looking for on these websites. And I thank you very much for your attention, and you are not alone. We are here for you. You can call the number. If you have any questions, I get the messages and I will call you back. Also, you can request information online at the Valley website, and it will go directly. You'll see a portal for the thyroid, parathyroid nurse practitioner inquiry, and you can send me a message and I will call you back and we can answer all your questions for you. Thank you.
Okay, wow, great, thank you. So we do have a couple questions that came in. A first question, does a hyperactive thyroid cause chronic fatigue? And if you have more questions, send them in, type them into the chat or type them into the Q&A.
Yeah. So hyperactive, it's kind of, I guess, secondary fatigue, because when you have too much thyroid, you're always, over metabolic. So, your heart rate is up, it's causing insomnia. And so, of course, if you're not going to sleep and you're going to be revved up, eventually it's going to catch up to you and you may get chronic fatigue. That's absolutely possible. But it's kind of indirect. It's not like Hashimoto's where your thyroid is not working well. You don't have enough thyroid to kind of, increase your metabolism, so you really feel tired. This is kind of indirect, where you're always revved up and at some point your body just exhausts itself, if that makes sense. Yeah.
Speaking of Hashimoto's, I know somebody had asked a question, do you treat Hashimoto's?
No, so I'm a surgeon. I like to limit my scope of practice to what I do best, and that's operate. But we do have excellent endocrinologists, in the area, that part of Valley system, and they're more than happy to take care of you. But again, if you have any questions about what's happening with you or your particular case, this may not be the forum, but you're welcome to reach out to us. And again, Kathy is really good and kind of trying to figure out what it is you need. Sometimes you just need your primary care doctor to take care of it. You don't need a subspecialist. So we can help you with that.
Great. What is hypothyroidism?
Hypothyroidism is basically when your thyroid is not functioning enough to produce enough thyroid for you. And so when we check your levels, it's low. So that's hypo, and thyroid just says low thyroid. So that's what happens. And it could be a couple of different causes. It could be because you had your thyroid out, for example. That's most of the time when I see patients, when I remove the thyroid, and then the patients have post-surgical hypothyroidism, because if I take you off the medication, you will not have any thyroid. But very often, we hear that when it's Hashimoto's, when your body is attacking your thyroid and your thyroid is not functioning anymore.
Do nodules and thyroid cancer present in women more than they do in men?
Both, yes, about 8-to-1 ratio. Women are much more likely to have nodules and are much more likely to have cancer. Yes, and I know the follow-up question is why, and we're not sure, but it seems like, we have a lot of hormonal changes in our life, from, going to getting periods, to then, having kids, some of us, to then going through menopause. So there's a lot of hormonal changes, and I don't know if that sometimes influences other parts. And this is total conjecture. There's no data behind this, but it just sounds like that makes sense.
Do you take a radioiodine pill for a scan pre-surgery?
Pre-surgery, you will take it if you need a scan to look at which part of your thyroid is overproducing. If this is cancer related, no. But if you have a nodule or you have a thyroid and overactive thyroid, then uptake scan and that pill that you're talking about in a much lower dose, yes, you would take that, and that'll tell us, is your entire thyroid producing this too much hormone situation, or is it just a part of it, like a nodule that's producing, because the treatment may be different. Hopefully that answers that question.
Great. All right. Those are all the questions we have tonight that came in. Thank you both so much for joining us tonight.